Hello, everyone, and welcome. My name is Gracie Van Amerongen, and I'm the membership manager here at Volta. Before we dive in, I did want to provide a little bit of an introduction. Volta is a student health platform that helps universities streamline immunization compliance, reduce administrative burden, and improve support for their students. We work with schools across the country to make health requirements easier for staff and for students. This series, The Current, is all about elevating the voices of campus health leaders. And today we are so excited to have Dr. Richard Keeling with Keeling and Associates joining us today. Founded in 1999, Keeling and Associates, K&A, is a national leader with 25 years experience providing specialized and highly customized consulting and executive search services to colleges and universities with an emphasis on student-facing priorities in student affairs, health, counseling, wellness, and student success. And with that introduction, I'll turn it over to Chikata to get us started.
Thank you, Gracie. Hi, everybody. My name is Dr. Chikata Pena. I'm the CEO of Volta Health before founding Volta. I completed my MD from Brown and got an MBA from Yale. Previous to that, served as a Fulbright Fellow and a captain in the U.S. Army Medical Corps. And this series about the current, it's not about Volta whatsoever. It's really about providing a space for folks that we all deeply admire and look up to be able to speak on current relevant issues in the space, because higher education is definitely going through quite a bit right now. And as we were thinking about uh, folks to bring in, Dr. Keeling was definitely on our list. It was just a matter of when do we bring him in, and so now that that first month of school has kind of gone through. We felt this would be a great time to bring him in, and we're really honored to have him join us. And just for brief bio, Dr. Keeling is the chairman and senior executive consultant at K&A, which is one of, if not the most premier higher education consulting firm. And today he stands as one of the most influential voices in all of higher education in America. And he's dedicated to transforming how colleges and universities approach student learning and institutional effectiveness. He earned a bachelor's of English with highest honors from UVA and received his medical doctorate at Tufts. And before K&A, he served for over 20 years as a tenured faculty member and senior student affairs administrator at UVA and the University of Wisconsin-Madison. He's very well known for being the editor and driving force behind the groundbreaking Learning Reconsidered series, which fundamentally reshaped how higher education approaches student learning. Rich argued for the integrated use of all of higher education's resources and educating the whole student, breaking down those traditional silos between academic and student affairs. And his 2012 critically acclaimed book, and one of my favorite titles, We're Losing Our Minds, Rethinking American Higher Education, challenges the quality and quantity of learning in American colleges and calls for fundamental change throughout higher education. But at the heart of Rich's work is the unwavering belief that learning should be transformative and must be at the core of every college and university's mission. KNA operates with four guiding principles: students first, equity, empathy, and value. Rich believes that at the heart of for the foundation of learning should be health and well-being. And with that, please join me in welcoming one of higher education's most respected visionary leaders and transformative thinkers, Dr. Richard Keeling. So, Rich, thank you so much for joining us.
Well, thank you. It's one of those introductions that makes you think you should say nothing and not disturb the positive impression already made.
As you can see, I was tripping up near the end there just because you've accomplished quite a bit, and leading into that, you've seen this field from both sides, right? For 20 years, you were an administrator on campuses, and then the next 20, you've been advising the people who hire those administrators. What made you run away from being an administrator? Why did you just start KNA?
Let me go back to the very beginning for a minute, because I think it's worth noting that I've been part of college health since my first year in medical school. I went to medical at Tufts in Boston, and my clinical placement for things like learning physical diagnosis was at Tufts University in Medford. And I would go to the student health service there every week and learn how to do physical exams from the director of the health service at Tufts at the time, who was a terrific guy named Phil Chase. And after that, went back to UVA, did my residency, included student health in my rotations. And after finishing residency and fellowship, was invited to lead the health service at UVA, which I then did for 13 years before going to Madison. Anyway, so I was on the user side and then the practical side, and then after we formed K&A, on the side of working with people who were concerned about student health and students' learning and well-being. And I made that transition because although I get the idea of running away from administration a little bit, because it certainly is an attractive thought, still I made the change because I felt that this field, college health, had enormous potential. That's why I stayed in it so long. But I began to think that I could make more difference looking at the field as a field rather than on a single campus. So I had great experience at UVA, great experience in Wisconsin. And since then, we've been able to work with lots of other institutions to try to improve student health care for many, many students. So that's why I'm doing what I'm doing.
No, that's incredible. I think the space is ever evolving and so much has changed, right? And like you've said, you've seen it from not only the administrator side, the advising side, but also as a user and trainee. What's changed over the past, 40 years?
Well, it's changed a great deal, and some things have not changed at all. And I'll just mention at the very beginning that one thing that's not changed is the passion that people who work in college health have for their work. And that's one reason people like me have stuck around for 40 plus years, is that it's great to work with people who are so dedicated, so caring about students, as you'll find in student health centers. But if you look at the field over that 40-ish years, you'll find a lot of change. Notably, for example, college health centers, which used to look really different, have started to look more and more like other outpatient medical services. That also means that people's expectations of them have become more like they're for other outpatient medical services. And unfortunately, we're often providing outpatient care for students without having the same resources that other outpatient medical services do. That's still true. We're increasingly focused on urgent or acute care. And although there was a time when people thought, this is a time meaning 10 years ago, people thought college health might develop a kind of primary care model, medical home, et cetera. It turns out that as things have changed in healthcare in general, students mostly prefer just to be able to get easily accessible acute care at the time they do from a person who's competent to give it to them. So they're less interested in longitudinal care than perhaps we thought they would be, or some of us are. But there are still students who need longitudinal care. It's just that that's not the majority any longer of the work that most college health centers will do. Third thing is that college health is much more involved in mental health than it was originally. There was a phase where most of the mental health work was done in college health by psychiatrists. Later, most mental health done by counselors in counseling centers. What's now happened is, because of the very high prevalence of psychological distress among students, it takes both. And college health centers, even though they're not necessarily integrated with counseling centers, they are collaborating with counseling centers to be sure that students get comprehensive, holistic mental health care. And that also has changed expectations. So many times in working with health centers these days, I hear that a third, sometimes 40% of the visits to the health center, not to the counseling center, but to the health service, are related to students having mental health symptoms. Other things that have changed are who it is providing care. There was a time that not only was the American College Health Association mostly led by physicians, but most college health centers employed physicians, and many were led by physicians. But now nurse practitioners, physician assistants are providing the majority of the care. More and more health centers have nurse practitioner leadership, for example. Fewer and fewer depend on physicians, and the role of the physician has been increasingly narrowed to very specific things. So turns out that the kind of care that college health centers provides needs physicians for some things, but not for many things. And nurse practitioners in particular, very effective, very well trained, actually, very caring in that role. Speaking of nurses, the roles of nurses have changed. When I started in college health, it was a doctor and a bunch of nurses. And these days, the registered nurses have more specialized roles. Some have become advanced practice providers, some do triage, some work under protocols, but many of the tasks that might have been nurses in the past have become managed by medical assistants or visiting nurses, not by registered nurses. The other thing that's changed is the embrace of external services. So it wouldn't have been thought in the past that you would have somebody else do your lab or run your x-ray or run your pharmacy. But now all of those things are increasingly common because you have more trouble trying to do it as a self-managed operation. And there are people who can come in to run the laboratory or do the x-ray service, and do that in a way that's often more efficient than the health service could have done it itself. That's also true for third-party commercial services to provide care and nights and weekends. And it used to be there was quite a struggle often to figure out, how do we make something available to students at night? Well, that's now possible through any number of available commercial vendors. And then all of that speaks to one other final change, which is financial challenges. And it's become true that college health as a business model, like colleges in general, is increasingly challenged. Rising costs, people cost more, healthcare providers cost more, and the revenue tends to be relatively flat, doesn't increase as easily as the costs increase. So student health centers are increasingly looking for other sources of revenue. And we may talk about that more later, about what some of those sources might be, but that's become a constant, is how do we make sure we stay financially sustainable? And then lastly, health centers now caught in the midst of the social and cultural debates over healthcare. So college health centers get caught because of state legislation or national changes that affect access to reproductive health care, et cetera. And the scope of care, therefore, gets adjusted sometimes in relation to things that are outside the control of the health center itself. And the health centers, I think, certainly when I was in practice in them, didn't expect to be caught in those kinds of tides of change. So that's what I see that's stayed the same, and that's what I see that's changed.
Not a lot has changed from what I hear. It does seem obviously the broader just kind of societal winds are converging onto campus health centers, and in one way, campus health centers are becoming more like what I call real adult healthcare. But what blind spots still exist today, right? From campus leadership perspective, what are those biggest blind spots? I know obviously, I can think of the economic factor that you spoke about, which I know we want to delve into more, but um, including that and beyond that, what else would you kind of say to that?
I think the certainly the point about social and cultural trends is important. That also affects how students want and get health information. There was an assumption for a long time that part of the role of college health centers was to provide health information for students. Then came, of course, the internet. And in the internet have come both commercial and nonprofit sources of information that students now rely upon. So fewer and fewer students depend on the health center to tell them about basic health questions. That also changes some of the people who do come to the health center, because some people now use internet as a way to answer questions that they might have asked in the health center. So second thing that I think is changing a lot is how the structure of an institution affects the health service. Many health services, of course, are part of student affairs divisions. And if you've been watching higher education in the past few years, you've seen a lot of changes in student affairs. And some of them are truly revolutionary changes. And I think for people working in health centers, we need to be aware of those changes because they do produce sometimes sudden significant change. An entire student affairs division might disappear. Leadership in student affairs might disappear. And then thirdly, we have to be aware of the consciousness of costs, that student health centers are perceived as cost centers. And as cost centers, they are therefore drags, if you will, on an institution's budget to some extent. So people in health centers sometimes get surprised when they find senior administrators saying, we can't keep doing this. We can't keep providing this level of care. We can't have this many people. And no, you can't have another physician, another nurse practitioner. The last thing is we have to watch on what's happening in higher education in general, because there's a blind spot sometimes about the enrollment levels. We're just well into now this demographic cliff of dropping numbers of students. But guess what? If there are fewer students, you need fewer things to serve those numbers of fewer students. So the net effect of all of that, costs, changes in student affairs, demographic cliff, et cetera, is that changes made may be coming from the upside. That is less within the health center, things being imposed on health centers, and those changes are more likely to be sweeping than tweaking. That is less of this, stop doing that, et cetera. So I think there's just a need for people in college health to be very conscious of what's happening around them.
Absolutely. No, and speaking about that, um, I think back to Hamilton and the song, Room Where It Happens, right? You have to be in the room, you have to have a seat at the table. You know, how should health leadership look to get a seat at the table? What keeps them from being heard currently, and with all these changes that are happening, if you're not in that room, you may be forgotten about. So, how should folks really think about that?
Well, history teaches a big lesson about that, which is that what it took was a public health crisis, COVID. When COVID happened, all of a sudden student health centers were elevated to very high importance because that's where testing happened, that's where vaccines sometimes happened, that's where surveillance happened, that's where treatment of students who had COVID would happen. And therefore, the health center became a really important part of how an institution responded to the pandemic. The good part about that was it increased respect for student health centers on a lot of campuses. The bad part is as soon as the pandemic went away, that all went away too. So some college health centers are left kind of, whoa, what happened? They loved me, now they forgot me. And that seat at the table problem was temporary. What's kept them at the table otherwise typically has been a kind of philosophical argument that they are mission centered. That is, that health is essential to learning, that the role of the health service, the work of the health service might be to deal with primary and acute care. The actual purpose of that work, though, is to keep students in school, to make them able to learn, to remove barriers to learning. And taking that attitude or that discussion has kept the seat at the table for some. Student advocacy sometimes helps. But on the other side of it, what keeps us from being heard sometimes is honestly, often health services are small fish in a big pond. That is, there's a lot else going on. An institution that also has an academic medical center, the student health service may seem like a kind of an afterthought. The other thing, good and bad, is that there's a relatively modest risk profile for student health services. So we don't threaten the institution particularly. There's nothing, they don't worry too much about us outside the parts of worrying about the relatively few institutions that still have infirmaries and management. People get very worried about what could happen overnight in an infirmary, things like that. But otherwise, there's very little malpractice risk, very little liability risk. The good side of that is the risk is low. The bad side is it doesn't attract attention. And The other thing is that I think health services, I always felt, I think most of my colleagues in the field would say, we're not really very well understood. That is, faculty and staff don't really exactly understand what we do or how we work, and especially people outside student affairs. But then two other things. One is it's possible working in college health, and I think this happened to me sometimes, you can get kind of an insular perspective. And you start thinking that the entire college, the entire university is about student health. Well, it's not, turns out. And the other is that the national trend of declining confidence in healthcare systems affects us. So people think of healthcare as being less caring, less relational, less kind of accessible and helpful than it used to be. It feels, how many times when I hear colleagues talk about having in adult life having something done, cataract surgery or something, it's like a machine, they say. You go in this and then this and then this and then this. And I think people have increasingly doubted whether people in healthcare actually care about you. So I think that actually affects the image of college health centers to some extent as well, trying to be efficient, but trying not to be uncaring in the process.
That's interesting. And this is fascinating because our last guest was Dr. Jim Jacobs, somebody you know very well, and one of the things he talked about near the end of our conversation was that point there, right? In which during COVID, he would be walking across campus and people knew him, right? I don't know if I don't know if he would say he was a celebrity, but people knew him, people respected him, people were thanking him. And now, he was challenging really the field. How do we stay relevant, right? And especially in this day and age in which, irrespective of what anyone thinks about politics, our health secretary, right, it has yeah, issues with vaccinations, for example. We're about to go into fall vaccine season and things of that nature. You kind of mentioned if you're not a problem, nobody thinks about you. And this might be a weird question, but should student health leaders ruffle a few feathers to make sure that what is important is being, from their perspective, is also being observed?
Yeah, I think there's a there's an old saying about college health, which was certainly true back during the days in the 1980s and early 90s when college health was trying to cope with HIV and AIDS, which was, as was true with social change nationally, every now and then you have to act up and in order to get attention to what's needed. And what's happened since HIV and AIDS is in the 90s was all related mostly to alcohol and alcohol related problems. Now it's mental health and the importance of dealing with students' mental health comprehensively involves student health centers for all the reasons we just talked about a few minutes ago. And now and then, people in college health are going to have to ruffle feathers to make sure that senior administrators understand what those challenges look like. Example, recently I've been talking with a staff at a student health center that doesn't have a psychiatrist, doesn't have access to a psychiatrist, and keeps being told that the institution can't afford a psychiatrist. Well, great example. Somebody say, I know it's expensive, but if we care about students, we're going to find some way to provide psychiatric care. So those kinds of feather ruffling, I think, is going to have to happen.
Yeah, and another thing too, I think Jim talked about this really in the context of insurance, and relationships with brokers, but numbers, right? People like to see numbers, and I think in this field, it's a little bit more qualitative, than quantitative, and do you think there is a way to kind of quantify the impact, right? Obviously, you can speak about retention, but it's not a causal effect, right? There's a lot of things that are impacting, retention and things of that nature as well.
Well, there, yes, and I think actually there are opportunities for those studies and demonstrations. I'll just mention two things. One is in some college health centers, there is now a regular practice of of doing coding for diagnosis and visit levels, et cetera, sometimes in connection with third-party billing, but not necessarily so. And one reason to do that is it allows you to quantify level of complexity of a visit. So then you can begin to say to administrators, maybe you think student health is primarily very low-level care. Many students do, in fact, come with only episodic minor illnesses and injuries, but there are students who have more complicated care. Here are statistics about the complexity levels for visits that we've been seeing, and that's been helpful. Secondly, is there have been studies, one of which was done when I was in Madison, that show that you can demonstrate the influence of certain treatments done in college health on students' persistence in school. That is, you can take groups of students, for example, who on a screening period indicated evidence of depression or anxiety, and then some of those students came for treatment, some didn't. The ones who did come for treatment have higher persistence and graduation rates than the ones who didn't. So there are ways to quantify the impact of college health, college mental health. It's just a matter of sometimes the infrastructure required to collect and use those data.
Right, right. And, I actually, definitely want to talk about leadership transition search, a lot of what KNA does, because I think you have a, really unique perspective there, but sticking on the finance aspect, right? What's funny is we were I was really just trying to understand the billing landscape of college health a while back, just because I just couldn't believe it really wasn't being done or done efficiently. So I read a New York Times article from 2007 or 2008, and that's the first time I encountered your name, and you were a really strong advocate for bringing back, or bringing billing into student health. Why is that from your perspective?
Well, I still am, and for probably the same reasons. Wow, 2007, 8. Well, I got started in the field when I was 7, so that's fine. Anyway, um, the uh, the issue back then and the issue now is about two things. One is diversification of revenue, and second is, as people in business would say, not leaving money on the table. So diversification of revenue is because most college health centers operate on one of two, or sometimes a mix of these two revenue streams. One is institutional support. That is just a budget line in the university's budget, or a fee. There's a student health fee, or sometimes it's a segregated fee, sometimes whatever, health and wellness fee. But more and more, there are fee-based services, except in small liberal arts colleges. Most of them are not just budget items anymore. The problem is that costs have grown faster than fees want to grow. Everybody's worried about the cost of going to college. And as tuition rises, fees rise, et cetera, typically an institution will say, yeah, we got to raise the tuition this much, so we can't raise the fees that much. And you can see where that squeezes. So the effect of that is to leave health centers often with relatively few other choices about what to do. The most obvious one is third-party billing. This is especially true since the great majority of institutions have health insurance requirements. So students have to be insured. If they're insured and their insurance would pay for care provided in health services, then that's leaving money on the table if you don't do it. And it also avoids having to raise the fees. So you don't have to raise fees as much or cost as much. And institutions who've begun doing third-party billing have been largely pretty successful at doing so. And they have all kinds of exemptions, that some things that don't get billed, they have ways that they can protect confidentiality for students who don't want parents or others to know that certain things were done or certain tests were done, et cetera. And the opportunity there is to create greater sense of control within the service of their own business profile. That is, so that they would have money for research and development, professional development, maybe hire another person if they had the freedom provided by a different source of revenue.
Right. Yeah. No, and obviously I know KNA does a lot of work with institutions, especially on this topic in particular. What from your perspective, have you seen that would get campuses to embrace billing or third-party billing more in a way that works for both the students and the staff, right? I've heard a myriad of things in which, sometimes a student may not want their parents to get an explanation
Sure.
of benefits for, what, and a lot of staff that I've spoken with, as soon as they mention the word credentialing and licensing, I mean, it's the end of the conversation, right? So, what would get folks to embrace it more from your perspective?
Well, I think first, just a comment on your point that I think you have to be honest about this, which is that doing third party billing is a change. And because it is a change, it would require people, both the staff and the providers and the students, to do things differently than they'd done before. Understand, though, that the person least likely to have it be a change is the student. They
Interesting.
had to do this
Which is
before they
odd, 'cause
came
I
to
feel like
college.
that's what I often hear, that
Yeah.
no, students aren't going to want this because their parents or this or that.
Right, and mostly students have had to take their insurance card when they saw the GP, the gynecologist, the dermatologist, whatever. And they'll have to do that during spring break, during winter session, in the summer between years, et cetera. So the people who are least unfamiliar with this would be the students themselves. We have to be a little empathic and say that some of the providers in college health came to college health to get away from all that. That it's, they didn't want to have to do coding and have billing. They like the idea, and I respect this. They like the idea that we could just be the provider and not worry about how long it took or whatever, and just be with the student and be as helpful as we can. Didn't have to put in codes and didn't have to charge for it, et cetera. I don't think that's realistic in the modern environment. And just as the just as the systems around us have changed, that one's changing gradually too. And in order for college health centers to be able to stay current, to have the staffing they need, to be able to do the professional development they want to do, they're going to have other means of having revenue. And we've been involved as consultants with a number of places that started doing this, and all the great fears that students would be very upset, parents would be all upset, and all that have not come true. There's a big fear about two things. One is about, quote, double dipping, that you're paying a health fee and you're getting charged insurance. Remember that all of us pay taxes that support the county hospital. But if we go to the county hospital, they're still going to charge us for things we do. So you have to differentiate. The health fee pays for some things, the charges to insurance pay for other things, but that's easy enough to clarify. So that's one thing. The other is people worry about, well, what about students who, as you said, don't want information to go or don't have money to pay a copay or whatever. And once again, institutions have very imaginatively designed systems, often by working closely with the insurance companies to be sure that the EOB, the explanation of benefits, doesn't compromise students' confidentiality, or giving students the option to do pay without charging the insurance. So it's all possible to do. All of that gets to then what would make institutions welcome this more. I think, like a lot of other things in higher education, it needs a kind of a movement. That is, we started doing much bigger mental health services because that school was doing it and those two schools did it. So then we start doing it. And there's a lot of the kind of peer comfort that gets developed. So the more people that do this, the more people will do it. The other is that there's pressure from students often about either increasing services or longer hours or something. You can't do some of those things unless you have more money to do them. And I think institutions over time, the revenue argument will win. The it's not such a big change argument may help. Other institutions doing it will help. And then students' expectations about what it is that they expect in terms of care will probably require it.
Right. No, and as we're talking about this question and this topic in particular, you need leadership buy-in, right? And I think one of the unique things about, your role is, you and your colleagues at KNA help with these presidential and VP searches, right? You advise the institutions. from your, I think over 350 institutions y'all have worked with, what do schools usually get wrong, right? When they're hiring for these, student health adjacent leaderships. Obviously, we could talk about all the positives all day, but I think, the juicier clips that are going to come out of this is what do they get wrong?
Well, there are some things that are commonly wrong. One is that I'm going to say that they can have a non-strategic preference for physician to be the director or leader. And I say non-strategic. That means there are some circumstances in which having a physician leader is strategically important. Example, many times institutions where there is an academic medical center, medical school across the street, etc., sometimes the kind of comfort level of having a physician leading a health service is really important. But that tends to get suggested lots of places where that kind of strategy is not really necessary. Similarly, there is sometimes a kind of non-strategic opposition to non-clinicians. And sometimes the best person to run the health service isn't necessarily a clinician. It might be a person who has a hospital administration or public administration degree. And those people, depending on the size and the scope, are often very capable leaders. Another mistake I would say that sometimes is made is insisting that candidates have pre-existing college health experience. And the fact is, it's a small pool. If you get down to people who have pre-existing college health experience, you're talking about not a lot of people for most of these searches, and having college health experience specifically is less important than it used to be because there are other ways of doing community practice that equally qualify someone to run a college health center. So there are community health centers. There are ways in which people have set up federally funded or federally certified health centers. Those people who've managed other outpatient care would do very well actually trying to manage college health centers. Yes, you have to learn about higher education, but you have to learn about the context for most jobs you would take. The last thing I would say is they fish in the wrong pond sometimes. And they are sometimes looking for people who probably would not want to make this kind of change. And so they'll look sometimes for anybody who's a primary care practitioner who's managed something. But in fact, some of those places are not so useful because they are hospital based. And hospital based care and student health care, outpatient care are pretty different things. Well, I guess the last thing I'll say is now and then people have said to us, well, we know good old Dr. Apeno. And he's a really nice guy, and we see him, he comes to the football games. And he mentioned to us that if we ever had a place in college health, he could come and take it. And I got in very big trouble once at one, I won't tell you which one of my institutions, because a donor to the institution who was a urologist was thinking of changing his practice level, sort of semi-retiring. And he thought the best thing he could do was take a job as the medical director in one of my health centers, which we were searching for at the time. And I said, no, no offense to urologists, but I don't think that prepares you for the work that we do. He got very angry, called up the president and told me he was going to take my job and stuff like that.
Oh, wow.
And happily, the president supported me, so I was still there. But there is this mistake that just anybody could run a college health center, and trying kind of taking that for seriously is a really bad idea.
Yeah. Does it, I would think, and my assumption is that the size of an institution would play a big role in this. Is that the only factor by and large in terms of having a doctor versus a nurse or an NP or somebody that has big adult healthcare experience versus somebody that's newer to the field, or are there other factors in your opinion?
It is a factor, but not by any means the only factor. The size certainly is, whether or not there's an academic medical center is a factor, geographic location is a factor. Some parts of the country are more used to non-physician leadership than others. Type of institution is a factor. There are a lot of relatively small liberal arts colleges where there have always had a physician director, and they keep having a physician director because that's just what they've already done. And there are similarly some institutions in which, because of either members of the board of governors or trustees, that they really want a physician director. Sometimes people feel that parents of students won't be as confident in the health service if there's not a physician director. So all of those factors come into this.
Interesting. You know, and as these conversations happen, it signifies a leadership turnover, right? And I think we talked about this on our last webinar as well, in which whenever anything is happening leadership wise, it seems like the entire world just stops around an institution, especially when it comes to, you know, obviously what we're talking about in student health. How does that, you know, impact that turnover impact the continuity of care and strategy, you know, in campus health, right? Because if you have somebody that's, you know, like in the army, they have folks switch out every 3 to 5 years, right? Sometimes it's good, sometimes it's horrible because then there's nobody knows what's going on, right? What's your perspective on that?
Well, first I'll say something that could get me in big trouble, but it's absolutely true. Because of the rest of the staff, there are a lot of college health centers that would run perfectly well without a director, at least day to day. And every now and then you need directors. I was one. Every now and then you need people like a director like me for guidance and vision and making big decisions, etc. But happily, the staff in many college health centers are pretty experienced, pretty dedicated, and they actually can keep the place going through transitions. The the problem that happens is sometimes the other side of that, which is that people have been doing the same thing the same way for a long time, kind of gets cemented. And then a new leader comes in and may not respect or may not value that kind of cemented structure. Well, that causes some conflict, etc. Um, Fundamentally, what we ought to care about is that quality stays sustained. And we also ought to care about periodically taking a look at the scope, the staffing model to be sure they're healthy. And sometimes it takes a leadership change to do that.
Yeah, it's really interesting. And as that change is going on for the other leaders around, right? So, how should they navigate that transition, whether it's above them or parallel or you know in the counseling center, whatever it may be.
Well, one thing I always say is that when there's going to be a transition parallel to you, above you, especially, buckle up because chances are that's going to change some things. And kind of being open to the fact that it may not change the most fundamental things. So let's adjust our anxiety level to what level of changes might happen. That said, I think it falls upon us as people who work in college health to be always ready to demonstrate our value. And we ought to have key performance indicators, we ought to have assessment, we ought to collect data, we ought to be able to say what difference we made, we ought to be able to say what we have assessed, how we have made improvements in our services, how students have been satisfied, what we've been hearing, et cetera, all those things. And we need to be ready that that could happen at any time. And then finally, we should anticipate the possibility of those changes by making sure that we are great collaborators. So if we're great collaborators between a health service and a counseling center, then a change in the counseling center leadership is less threatening. If we're great collaborators with the basic needs office and things, same thing. Changes are less threatening.
Right. And you know, speaking about kind of, you know, proving your values, so to speak, as I think time goes on, health centers may need to start doing more with less. Um, what are, what would you say is one key thing that they should stop doing actually to make a better use of their limited resources?
Among things they should stop doing are things like, if they still do, is having their own staff cover after hours and weekends. And there are more economically feasible models using external services for things like that. There also are a lot of outdated processes, some of which are still done manually. Things like immunization clearances and health insurance waivers, et cetera, that sometimes just take up a lot of time and a lot of personnel time that could be done much more efficiently in other ways. Um, they also should stop doing things that are kind of providing just basic health information to students, because students have lots of other sources for that, and trying to do a tremendous amount of evening or expended budget trouble to try to educate students about things that they get better information about honestly from the internet is probably not a great thing to do either.
Yeah. Obviously, efficiency is certainly one thing that we believe in here at Volta. But as we, start to, wrap things up, we actually, just had a question come in, which I think, would be, interesting. How would you say someone with healthcare administration degree differs from the clinician that's leading it, right? And I think this relates to the question that we were speaking about before in terms of leadership and the types of leaders at, different types of institutions. So I think, this question is really, what are the pros and cons, right, of somebody with a, an MPH or healthcare administration degree versus an MD that's more of a practitioner.
Well, as you might expect, there's certainly advantages, disadvantages for each one. But just take a couple minutes on those. The healthcare administrator may be increasingly important as health centers become more business oriented in terms of their practices. So if, for example, if people take up third party billing and then there's necessity for increased internal management of resources, then healthcare administrators may actually be strong guides for getting into, through, and successfully using those kinds of practices. Um, if the health service, on the other hand, has a priority about kind of community engagement and involvement, and MPH, people with public health backgrounds, can be extremely effective leaders. And then, of course, physicians are, if the primary focus is going to be clinical leadership and campus health leadership for that role, then the physician leader might be advisable too. Note, however, though, that those people or those kinds of positions can be effective even if they're not the director. So you could have you should have actually somebody in public health, you should have somebody in administrative capability, and sometimes, many times, you need a physician, but you don't necessarily have the fact that you need those people's expertise doesn't necessarily mean that they have to be the director. The point about being the director is you want someone who can lead, not just manage, but lead, and who is credible and collaborative and will make the other people on campus, the other students and the other organizations on campus feel comfortable that student healthcare is in good hands.
Right. And as we, got that, one of our first questions, now we have a barrage, a wave of questions coming in. So I'm going to try to, squish some of them up. And, just to plug for CanA, if you do have more questions, I think, CanA is always, willing to do more consulting. So I'm sure you're happy with that, Rich. But, one of the, two of the questions that came in and that we're going to, kind of combine is, how should student health and counseling centers work more effectively together, right, to address some of these mental health concerns that are happening, and especially in light of the rising demands for mental health support. And similar but a little different than that is, what's the role of wellness and health promotion in this world, right? It's something from my perspective, and I'm still very much learning a lot about this field, is the newer kid on the block, right, in terms of counseling student health. So that I think that's a very interesting question as well.
So for health services and counseling centers, the most important things are that from a whole campus perspective, there is a mental health strategy, some of which is operated by the counseling center in terms of treatment that it provides, assessments, crisis, etc. Some of it might be provided by the health center in terms of practitioners who can provide for psychotropic medications and psychiatric evaluations, etc. Those things can be organized in lots of different ways and work fine. So sometimes they get integrated. So there are lots of places where health and counseling are in the same organization, reporting to the same person. Other places where they are in the same organization reporting, but not integrated in a merged sense. Any of those things can work as long as there is clear understanding of what each place does. And that can be shown to students as the mental health strategy for that campus. It's important that that requires collaborative ability to do case management. So between the health and counseling services, it ought to be possible for the people in the health service who provide medications, in the case that that's what happens, to know what the people in counseling service have done, the counseling service to know what medications have been used by the people in the health center, et cetera. And there are lots of questions about how best to do that. Often there are shared medical records, or at least ways of sharing parts of electronic health records that would meet the need of having everybody who's taking care of a student know everything about that student. That doesn't mean that the people doing prescribing have to know the details of the counseling history. It does mean that they have to know what's happened in general, and the people in the counseling ought to know that there have been certain medications prescribed, things like that. And happily, from what I see, most of that is becoming kind of normative. That is, that everybody expects health and counseling centers to be very collaborative, and more, I think that's true. On the other question about wellness, this is a really important development that reflects another one, which is concern about how students holistically thrive or don't thrive when they're on campus. And the movement toward thinking in terms of wellness is really not just about health information, not just about clinical services, not just about the care that's provided in places. It's also about how the institution demonstrates that the health of students matters and how they promote the health of students. And often that idea of health promotion rests in this concept of wellness. Important to say that wellness and health promotion, not the same thing as health education. Health education is like, you have diabetes, what do you have to do? You have allergies, what do you have to do? You have asthma, what do you do? Those things, extremely important, often done in the health service by a health educator. But the idea of health promotion, which is how you make the experience one through which students can thrive, be well, have the best version of themselves, all of that is what wellness is about. And the wise student health centers have fully embraced that and become part of how that work is done, even though all the work may not be done within the health service.
Yeah, no, and yeah, very, very, poignant point. As we wrap up the hour, I have two questions left, and I asked, similar questions to Jim as well. Let's imagine you have a magic wand, right? You could change one thing about how universities support student health. What would that be?
The single thing I would love to change is that the health service ought to be able to manage itself and make its own decisions using resources that it generates, and using those resources in the best way needed for the sake of the students. Which means, if we think about this in the concept of health services being kind of ancillary services or auxiliary services, so they are not therefore subject to, certainly they're subject to oversight, but they're not subject to supervision or close management by people who don't know about healthcare, don't know about health and students, and don't understand what it is that health services do. So I'd like to see them become increasingly able to manage themselves, develop their own resources, and provide the care that students need.
Yeah.
That's
And
a
then,
big magic wand, by the way.
yeah. Finally, 40 years is a long time, very long time. What keeps you motivated, right? In this work, is there a recent moment that reminded you of why that matters, or um, you know, why do you wake up every morning and are excited to do this work?
Um, well, first place, I'll say that um, I love the field, and I what I experienced going out to Medford, Massachusetts as a first and second year medical student with Phil Chase is still there. And the fact is that college health demonstrates a belief in the potential of students that is really essential in higher education. And there are lots of other places in higher education that develop students well, that work on educating them, their learning, et cetera. But college health nicely takes the perspective that whoever you are, we want you to succeed here. And we're going to do what we have to do to make that possible. And that's why you will find college health staff members, providers doing really extraordinary things. And you still do find them doing those things to try to make sure that students are healthy and thrive and succeed. So I think that's what keeps me going. And the other thing is that after all, the patient population, so to speak, is amazing. And the patient population is also pretty responsive. And yeah, they do crazy things and they don't always do what you tell them and all that. I get that. But on the other hand, spending time with students in a health service, you have the sense of potential
Yeah.
and the responsibility, the obligation to help achieve that potential. I feel very strongly.
That's an incredible way to end things. Rich, Dr. Keeling, thank you so much. I know we had over, a few hundred people here on the call, and I learned a lot, and I'm sure everybody else did as well. And after this, we'll definitely get out your contact information for folks to get in touch with you. But thank you everybody for joining us, and really excited for a few weeks from now we're going to talk to Dr. Carlo Ciotoli, who used to be at NYU. Now he's with Wellfleet Insurance, somebody that Rich knows very well. And we're really excited to hear his thoughts as well, especially as we go into what we consider at Volta insurance season. But again, Rich, thank you so much, and we look forward to seeing everybody again soon.
Well, you're welcome, and thanks to everybody for joining us. And be sure to come in for Carlo. Carlo has a uniquely international perspective on college health.
Absolutely. We're definitely looking forward to it. All right. Thank you again, Rich.